Welcome, dear colleagues, dear intensivists, wherever you are in this world. A very special session we have today, and we have a very special guest with us. It is indeed a pleasure and honor to have him with him here on our webinars, Professor Manu Malbrain. He's very well known to most intensivists, and he has done pioneering work in intra-abdominal hypertension and abdominal compartment syndrome, and of course, even fluids. So just to briefly introduce him, Sir is internal medicine intensive care CMO Madam in Belgium. He is professor critical care research, first department of anesthesia and intensive therapy, Medical University of Lublin, Poland. He is president of the International Fluid Academy, and most importantly, he is the founding president and treasurer, World Society Abdominal Compartment, in which he's the pioneer and he has given us this concept, and we are really thankful to him for this. He has more than 300 publications with greater than 32,000 citations and an H index of more than 82. Indeed remarkable, sir, and we really thank you for sparing your time and being with us. Over to you, sir.
Thank you so much, Tapesh, for this very nice introduction. It's really a pleasure and an honor to be here and to share my knowledge with you all. So I'm going to try to share my screen now.
Om het dempen tijdelijk op te heffen.
For some reason, my computer starts talking whenever I'm in Zoom. So can you see my presentation?
Yes, sir, we can see.
Okay. So let's kick off with this tutorial on intra-abdominal hypertension, from the basics to the most latest and recent evolution. These are my conflicts of interest, and as said, my biggest bias being the co-founder of the WSACS, aka now the Abdominal Compartment Society. And this journey started in beautiful Noosa in Australia in 2004, where we had Fox Creek Wines as a major sponsor. At the time it was possible, but it was raining cats and dogs. So instead of enjoying the weather, we were sitting inside, enjoying the wine and writing down the consensus definitions. So today I will give a brief overview of intra-abdominal hypertension and abdominal compartment syndrome. And most of all, we will try to break some bad habits. So intra-abdominal pressure, is it fact or fiction? If I would ask you who is measuring it, I guess about maybe 25–35% of the delegates would do so. Still, there is a lack of general clinical awareness. So today, the learning objectives will be, after a brief introduction, I will discuss some pathophysiology definitions, how to measure the risk factors, how intra-abdominal hypertension impacts organ function, and then how you can introduce it into your daily clinical practice and some take-home messages. So let's kick off with a introduction. Why do you need to know this? Well, maybe you don't. Maybe you like it because some still think it's something new. I may not know everything, but I'm convinced that it will change your clinical practice if you will introduce intra-abdominal pressure to it. If you would perform a literature search, you will see an exponential increase in publications on intra-abdominal hypertension. But yet, most surgeons and anesthetists don't care about perioperative intra-abdominal pressure. Let me illustrate this with the typical case after abdominal sepsis, perforated viscous in the ICU. After surgery, blood pressure drops, Patient gets a bag of saline, low urine output, another bag, low CVP, yet another bag, and so forth. Why is that? Because it's kind of a reflex. Whenever something is going wrong in the ICU, we try to correct this by infusing volumes and mainly abnormal saline. So on the second postoperative day, you can see the abdomen is distended, the function worsens. And then on day 4, there is a further increase in creatinine and a positive cumulative fluid balance of +7 liters, and the patient is on CVVH. On day 7, suddenly there is cardiac arrest in the ICU because of acute mesenteric ischemia, and the patient eventually died. The question is, did you measure intra-abdominal pressure? This is a burn case, distended abdomen, low tidal volume, high peak pressure, and suddenly cardiac arrest. So what did you see in the patient in the burn unit? Severe burns, fluid overload, hypothermia, abdominal distension, high peak pressures on the ventilator above 55, low tidal volume, only 130 ml, and then cardiovascular collapse. Because intra-abdominal hypertension and compartment syndrome are real and may kill patients on a daily basis. Question again, did you measure the intra-abdominal pressure? I consider AIP next to traditional vital signs like heart rate, blood pressure, saturation, respiration, temperature as the sixth vital sign, and maybe also we should look at urine output. Let's take a look back into history. And it was as early as 1331 when Guy de Chauliac discussed abdominal decompression avant la lettre, as they say. In the 17th century, Johannes Schultnys and Paul Barbet described different techniques to open the abdomen. And in 1657, it was the Dutch surgeon Nicolas Tulp who described repetitive decompressive measures with this wooden device, and this was especially helpful in patients with cirrhotic ascites. In this is Nicolas Tulp, where he's doing anatomic dissections. In 1863, it was the Frenchman Etienne Jules Marais who performed studies in animals and men and showed that the pressures in the thorax and the abdominal compartment are opposed, and increased intra-abdominal pressure also affects the thoracic pressures. In 1881, it were the Italians Mosso and Pellacani who described the first device to measure intra-abdominal pressure via the bladder, and this was in a study in pigs. In 1991, the first review was published by Haven Emerson, describing a direct intraperitoneal pressure measurement device. This is a landmark. It's the Eiffel Tower in Paris, and this is another landmark. It's the Atomium in Brussels, Belgium. And these are two landmark papers who were published now almost 20 years ago on the incidence and prevalence of intra-abdominal hypertension in critically ill patients. So altogether, there were about 265 patients from 14 centers, mainly Belgium and Italy. And if we look at maximum abdominal pressure was around 10 millimeters of mercury, with equally a mean also around 10. And this is in mixed ICU patients. When we look for etiologic factors, they were related to abdominal infection, surgery, fluid resuscitation, and ileus. And if you look at predisposing conditions in relation to intra-abdominal hypertension, It's acidosis, hypothermia, transfusion, that's the deadly triad, as well as sepsis and liver failure dysfunction. The incidence in medical patients, pressures above 12 was around 30%, as you can see in dark blue, but compartment syndrome, pressures above 20, mainly present in emergency surgery patients. So the higher the intra-abdominal pressure in yellow, the higher the mortality in red. And if abdominal pressure goes beyond 25 millimeters of mercury, mortality was as high as 75%. ROC curve analysis identified a threshold of 12 millimeters of mercury being the best predictive parameter for outcome. And if you then look at the Kaplan-Meier survival curves in this study of 265 patients, you can see that the ones with abdominal hypertension above 12 millimeters of mercury have a higher mortality and less survival. So afterwards, we published a systematic review of all studies looking at the incidence of abdominal hypertension. And we found that the presence of abdominal hypertension was an independent predictor for ICU mortality. Looking at other risk factors, we identified fluid loading, and you can see that most of the patients now are in grade 1 and 2 intra-abdominal hypertension and less in grade 4, which is pressures above 25. So the bottom line of all these studies is that about 25% of ICU patients have a pressure above 12 on ICU admission, 50% will develop it in the first week, and 5% of patients will have abdominal compartment syndrome with a very high mortality. So you need to measure the pressure in order to understand and diagnose the disease. Was this also so in COVID-19 patients? Yes, it was, and especially during the first wave, where we had obese patients with comorbidities receiving lots of fluids. Intra-abdominal pressure was an issue also during prone positioning of these patients. So let's now move on to the consensus definitions. And I thank Bruno Pereira for sharing some of his slides. And this is the W-SACS consensus paper. First was published in 2006. And this paper was long the most cited article from intensive care medicine and already has a lot of citations. In 2013, we published the revised guidelines, and this paper is available under open access, so you can download it for free. And we are now working on the 2024 revisions. So what is intra-abdominal pressure? It's the steady state pressure within the abdominal cavity. As any body pressure, you measure at the end of respiration. Because we consider the abdomen to be primarily fluid in character, the pressure will be equally transmitted. So normal pressure is around 5 to 7. In ICU patients, I showed you, is around 10. And the higher the pressure, the more the impact on end organ function. After abdominal surgery, you can see pressures around 10, 15. In septic shock, they can go even further. And emergency surgery and trauma with acute bleeding, you can have pressures in the range of 20, 30 millimeters of mercury. So intra-abdominal hypertension is a sustained increase of abdominal pressure above 12 millimeters of mercury. And if you don't do anything about it, it's associated with poor prognosis. We have grade 1 to 4 abdominal hypertension with cutoffs at 12, 15, 20, and 25, as you can see there. An abdominal compartment syndrome is a sustained increase above 20 millimeters of mercury with new onset organ failure and dysfunction. So usually there will be problems with a ventilator, as you can see in the burn case with very high peak pressures and low tidal volumes. You can get cardiovascular collapse and the kidneys are considered the canary in the coal mine, resulting in oliguria, anuria, and so forth. Then there are different types of abdominal hypertension and compartment syndrome. So primary is when there is a problem within the abdominopelvic region. Secondary hypertension ACS is when it does not originate from the abdominopelvic region and mainly due to capillary leak, as we can see in burn, sepsis, or after massive volume resuscitation after thoracic trauma, for instance. And then recurrent hypertension or ACS is after initial medical or surgical management for primary or secondary hypertension or ACS. And this is also known as previously as tertiary abdominal hypertension or a frozen abdomen. If we look at the abdominal compartment, we have different constituents that will relate to intra-abdominal volume and intra-abdominal pressure. So I said it's primarily fluid in character, but other factors will determine a certain intra-abdominal pressure with a certain intra-abdominal volume, like gravity, the uniformity of the compression, shear stress, and abdominal muscle contractions. So when the pressure in the abdominal compartment increases, this pressure will be transmitted to the intrathoracic compartment and also to the intracranial compartment. And on average, this transmission is about 50%. This leads to the definition of the polycompartment syndrome, is a condition where two or more anatomical compartments have elevated compartmental pressures. So you have the head, the cranium, the thorax, the abdomen, and the extremities. So those are the four major abdominal and body compartments. If you look at the abdomen in a normal situation, this should be a sphere in sphere-like shape, and this will further become more and more circular due to reshaping and then stretching. And once the fascia is fully stretched, there will be pressurization. So it goes from an oval shape to a circle shape, and this determines the abdominal compliance. So it's the change of volume and the change of pressure. Likewise, we can see this in the brain as well. So the abdominal compliance may be a very important parameter that is often neglected to understand organ-organ interactions. Brings me to the next point, which is the measurement of intra-abdominal pressure. I told you the abdomen is primarily fluid in character, so you can measure the pressure in the bladder, in the stomach, direct peritoneal or rectal pressure measurements have also been described. So direct measurement in the peritoneum, indirect via the bladder or via the stomach. So the gold standard is the bladder pressure measurement. How to measure intra-abdominal pressure measurement. So we'll try clinical assessment. You measure intra-abdominal pressure by putting one hand on the abdomen and estimating it. Well, if you're a surgeon, you maybe can, but it's not by putting one hand nor by putting two hands, or using an abdominal perimeter that you can estimate intra-abdominal pressure. The reason is that sensitivity and positive predictive value is low, so it's not accurate. Direct techniques. So this is a direct measurement. in a patient with severe acute pancreatitis. And the pressure was 42 centimeters. In the ICU, we don't use direct measurement. Why not? Because it's quite invasive and at risk for infection or bleeding. So then how to measure intra-abdominal pressure is via the bladder after instilling a maximum of about 20-25 cc for priming. Patient should be supine at the end of expiration with the zero reference where the mid-axillary line crosses the iliac crest. And there are many techniques developed. You can identify a homemade peak, or you can use the height of the urine column. And this is called the Foley manometer. As you can see in this video, the zero is not quite correct. It should be where the mid-axillary line crosses the iliac crest. And you see the urine column coming down at a certain level, and the meniscus will go up and down with respiration, and there is your AP. You could also use a transducer that you connect to a regular Foley via maybe the culture aspiration port, or a homemade system like you can see there, a ramp with 3 stopcocks, and that is illustrated in this video. It's quite old, but I think it summarizes how to do it. So you have the ramp with 3 stopcocks. You aspirate first some sterile saline. It says 50, but studies have shown that 20 cc is enough. And then you open the stopcocks to the pressure transducer. That could be the same transducer used for central venous pressure, and you have intra-abdominal pressure measurement on the monitor, which in this case was 20 millimeters of mercury. Nowadays, there are also continuous techniques available. So either direct via the bladder or via the stomach. So direct continuous techniques can be done with a catheter that has an extra balloon connected to a Spiegelberg monitor, and that you can place directly to the peritoneal cavity. You use a regular Foley catheter for continuous bladder pressure measurement. You cannot, because urine needs to drain. Otherwise, there will be a buildup of pressure in the bladder. And if you drain it, pressure will be -30. So with two-way Foley, it's difficult, but with a 3-way Foley and a continuous irrigation, theoretically you could. But every time the patient moves, this will alter your pressure measurement. You can use a stomach catheter like a Spiegelberg nasogastric probe that allows continuous monitoring, as you can see in this video with place. No. Yeah, it's not playing, but it's a regular nasogastric probe. With the extra balloon, you can measure ARP continuously. This was a former device. It's no longer available. That was also regular nasogastric probe, allowing continuous stomach pressure measurements. Now, today there is another device available, which is the Acrin, and it's a Foley catheter with an extra small balloon on the tip, as you can see. And via this balloon, you can have continuous bladder pressure measurements. And while having continuous measurements, you can see in this patient that developed peritoneal hematoma. When it was drained, then the pressure came back to normal values. So to have it continuously is interesting. This is an Israeli company that developed disposable that you connect to any regular Foley catheter and allows continuous bladder pressure measurement as well as urine output. And the last device that recently became available is the Trauma Guard from an American company, Sentinel Medical, that has 3 balloons. So this is a balloon in balloon. So it's a pressure measuring balloon that is covered by a protection balloon. It connects to any monitor that you have in the ICU with a smart cable. And we were recently able to validate it in an in vitro model. See here, this phantom mimics the height of the water column, respiration with a piston, as well as heartbeat. So in this in vitro bench top model, we compared the trauma guard with other devices like the Acurin, the Spiegelberg, the Simon, the Sereno. As you can see in this set, we tested an empty bladder and a full bladder, and you can see that the trauma guard is able to measure a superimposed pressure of 50 millimeters of mercury also with an empty bladder. Good correlations, good Blunt and Altman reasonable limits of agreement, a very good concordance. So if the pressure goes to one direction, the trauma guard kept track of changes as well as error grid analysis. And now with this device, we are able to monitor bladder pressures continuously and have real 24-hour trends. So why would continuous monitoring be the future? Well, other pressures are also measured continuously, like blood pressure or central venous pressure. And just 10 good reasons. You have a trend. You can assess the effect of your treatment. You also have abdominal perfusion pressure as a trend. Look at the time above a certain threshold or the area under the curve. So it's the pressure time burden, the compartment interactions, the pressure transmissions from abdomen to thorax and thorax to abdomen that allow you to adjust the ventilator and have an idea of compliance. This is an illustration. If you would not measure continuously, you would have the 4 red dots and a mean pressure of 9. You would have missed the high pressures up to 23 in this patient on peritoneal dialysis. So when you change body position, there will be a change in intra-abdominal pressure. And on the bottom right, proning is important to hang the abdomen free in order to prevent increases in abdominal pressure. If we would measure in the stomach, you can see migrating motor complexes. So motility, contractions over there, you could see peristalsis. And having continuous tracings allows you to calculate the area above a certain threshold for the time that the patient has a high intra-abdominal pressure. So I think in the future, like we look at intracranial hypertension, the pressure time burden will be important. And then with specific software, you analyze the time that the patient had a normal pressure or increased pressure, and you can see the effect of paracentesis, pressure coming down, and then there was a bleeding hematoma. You see the pressure is increasing again. With continuous pressure, you can see the end inspiratory, expiratory variations. And in this patient that is fighting with the ventilator, the forced expiration has a very high expiratory pressure of about 24, which you can see in COPD patients. So I think continuous monitoring is the way to go for many reasons. You have continuous intra-abdominal pressure, you can have fusion pressure, automatic calculations, compartment interactions, transmission of pressure between different compartments. You can adjust your ventilator recruitment and have an idea of compliance of the abdominal wall. So here you say, it's all very nice to have this kind of monitoring tool, but so what? What should we do? And when should we measure intra-abdominal pressure? So with the society, we said that when there are 2 or more risk factors related to increased intra-abdominal volume, intraluminal volume, to fluid resuscitation, or to diminished abdominal wall compliance, you should start measuring. So more than 2 risk factors, intraluminal contents, intra-abdominal contents, capillary leak fluids, and compliance of the abdominal wall that could be related to non-compressible intra-abdominal volume, anthropometry, could be related to abdominal wall itself or to diaphragm actions. So let us briefly go over these risk factors related to, first, increased intra-abdominal contents. So these are common to ileus, antral feeding, gastroparesis, gastric distension, you name it. So these are well-known causes of increased intra-luminal content. Intra-abdominal content, well, most likely is free abdominal fluid, as we see in second space, third space fluid accumulation. After major trauma, also in patients with peritoneal dialysis, patients with liver cirrhosis, think about severe acute pancreatitis, pregnancy, of course, laparoscopy. So these are conditions with increased intra-abdominal contents. And most of all, it's related to leak and fluid resuscitation, where the combination of acidosis, hypothermia, and coagulopathy has been referred to as the deadly triad that leads to ongoing fluid resuscitation and leak. Fourth is anything related to a diminished compliance of the abdominal wall. And here we have the four conditions: anthropometry, non-compressible intra-abdominal volume related to the abdominal wall or the diaphragm. Just to illustrate that this is little statues, the Venus of Vestornici versus the Venus of Willendorf. And you can see that the statue on the left will have a much better abdominal compliance than the statue on the right. So the waist to hip ratio is important. Other factors related to it is that men usually have lower compliance, also younger age, then you have more recoil. Obesity will result in a lower compliance, and other anthropometry features like the abdominal perimeter or the sagittal abdominal diameter. Non-compressible volume, well, we know that air, gas is compressible, whereas fluid is not compressible. So whenever there is a fluid collection, this will result in a diminished compliance. Then you have the dysfunction of the diaphragm related to mechanical ventilation or the high PEEP setting, or patients with COPD, emphysema, or pneumothorax. And then we have factors related to the abdominal wall. As said, men usually have lower compliance because they have more muscles, like six-pack seen in a bodybuilder. When there is infiltration of the interstitial tissue because of fluid accumulation, anasarca, this will result in a poor compliance of the abdominal wall. So I think I listed you a lot of risk factors. Whenever there's two or more risk factors, it should be good to obtain a baseline intra-abdominal pressure measurement. So now we know what it is, the definitions, we know how to measure, we know when to measure, and the following question is, okay, why is it important? And again, return of spontaneous circulation. So what did you see in this movie? I think is very realistically done of emergency room. We saw a patient with pancreatitis, free abdominal fluid. We've seen that the intra-abdominal pressure was around 30 millimeters of mercury. Because of that, abdominal compartment syndrome, cardiac arrest, CPR, but no return of spontaneous circulation, ventilatory failure, and diagnosis was a primary abdominal compartment syndrome and restoration of spontaneous circulation after decompression. So I think this case nicely stimulates that When we are giving fluid resuscitation, case of sepsis, there will be second and third space fluid accumulation, elevated intra-abdominal pressure, bowel edema, compression of the vena cava, reduced blood flow, return to the heart with a reduction in cardiac output, reduced blood flow to all other organs, and this may trigger a multi-system organ dysfunction and failure cycle. Because when the pressure in the abdomen is increased, this will have a dramatic impact on all organ functions, not only within the abdominal cavity, but also far outside. This is just a list of the cardiovascular effects of raised abdominal pressure, and the list of pulmonary effects is even longer, as you can see over there. So briefly, intra-abdominal hypertension affects all organ function, so it will increase also intracranial pressure, may result in intracranial hypertension. Intraorbital hypertension has been described also in patients with burn resuscitation, and this results in a diminished cerebral fusion pressure. When it comes to the heart, we see a drop in blood pressure, resistance increase, contractility decreases, filling pressures are increased because of the increase in intrathoracic pressure, reduction in venous return, reduction in cardiac output. Here you can see what happens to the central venous pressure if you increase intra-abdominal pressure, and hence you can calculate the index of transmission from the abdomen to the thorax. So on average, this is about 50%. So you can easily calculate transmural CVP by subtracting half the intra-abdominal pressure. And this is why volumetric load indicators better reflect the true volemia status in patients with abdominal hypertension. So CVP will go up, whereas global endostolic volume will drop. And this is summarized in this open access paper. What happens to the lungs? Well, we will have also increased in pressures, alveolar pressures, peak pressures, low tidal volume, as you show on the video in burn case, may result in increase in extravascular lung water, poor oxygenation, poor ventilation, difficult weaning, and so forth. Reason is that if abdominal pressure is increased, the chest wall elastance plays a major role. And if you have a sticky atelectasis in a patient with normal abdominal pressure, then you may be able to recruit by an applied pressure of 60 millimeters of mercury, saying that you need 30 centimeters of water to open the lungs. But if you have a high abdominal pressure, the ratio between lung and chest wall elastance will be altered, and the transpulmonary pressure will be lower, and you will not be able to recruit lungs. So that's why when you are recruiting the lungs, you need higher opening pressures if the patient has abdominal hypertension. And when it comes to the deflation limb, setting the PEEP in order to prevent collapse, you will need a higher PEEP to keep the lungs open. That's why you can set the PEEP in centimeters of water at the level of AIP in millimeters of mercury to counteract the effects of increased intra-abdominal pressure. And you can see in this video, again, it's not working, but on the right you can see that there is dorsobasal atelectasis, especially after neuromuscular relaxants. So you need to recruit dorsobasal regions. So what if there is ARDS or like COVID? This is oleic acid injury in pigs, and you can see that the lungs are white or flooded. If you put a pressure of 40, you can recruit. But if intra-abdominal pressure is increased, you can see that the diaphragm is moving up. And for the same pressure of 40, you only have recruited half of the lungs. Why? Because the opening pressure is not 40, but 40 minus 20. And you can see that if you have oleic acid injury, then it's normally the dorsobasal regions that are wet. If you increase abdominal pressure, the whole lung gets flooded. In the gastrointestinal tract, the same. You can have ascites. You can also have interstitial edema. When bowels are edematous, contractility will drop and you will have ileus, further distension, and this may trigger a vicious cycle. Also in the liver, there will be alterations mainly in lactate metabolism, liver perfusion, as well as mitochondrial dysfunction. Kidneys are usually considered as the canary in the coal mine. So when abdominal pressure increases, there will be a drop in diuresis leading to oliguria and anuria because of renal venous pressure increase, so renal venous hypertension, venous congestion, resulting in a drop in blood flow. There will also be salt and water retention. So wrap things up, I hope I convinced you that intra-abdominal pressure is really a very important parameter. And when it comes to AKI in patients with sepsis or in the ICU, it is really the canary in the coal mine. You can read more in this recent book on the polycompartment syndrome. I hope that in the future we will have continuous intra-abdominal pressure measurement techniques readily available, like for instance with the Acrin or the Trauma Guard, where we have a trend of intra-abdominal pressure, a trend of abdominal perfusion pressure as a resuscitation target. It's very important to measure intra-abdominal pressure because it impacts everything you do to your patients in the ICU. Think about the polycompartment syndrome. Think about transmural filling pressures using volumetric preload targets. It will also alter your PPV and SVV target. Passive leg raising may be falsely negative if abdominal pressure is increased. It has an impact on gastrointestinal function, on kidney function, on the presence of ileus. So when abdominal pressure is increased, you may need to lower the speed of your enteral nutrition. Think also about abdominal perfusion pressure as an impact on liver function and lactate metabolism. There's a large relation with how setting the ventilator with respect to recruitment, opening the lungs and keeping the lungs open, also in relation to prone ventilation. And also there are hormone disturbances when abdominal pressure is increased. So it is key to start monitoring it. And if you want to learn more about it, you can have a look at the book, which is available by Cambridge University Press. There is another book on compartment syndromes as well, and this is open access, a clinician's guide to the management of intra-abdominal hypertension, published a couple of years ago in critical care. So I would like you to go home with the knowledge that clinical estimation is unreliable. So you need to measure it to detect intra-abdominal hypertension. Use the technique that your nurses will use. So bladder pressure measurement is the gold standard. Remember that 1 in 4 of the patients will have abdominal hypertension on day 1 and 50% within the first week, especially in COVID-19 patients. Think about the risk factors and the consequences of fluid resuscitation. Has an enormous impact on end-organ function. Didn't discuss much on the different phenotypes when it comes to ARDS and COVID, but also enormous impact on outcome and clinical management at the bedside. So I think it's time to act now and start measuring intra-abdominal pressure. And having said that, I invite you to join the WSACS members platform, and you can sign up for a lifetime free membership. Thank you for your attention.
Thank you very much, Professor Malbrain, sir. Wonderful presentation, lovely listening to you, and really wonderful, colorful. So, some questions have come up. So, the first question, sir, is from Dr. Mocano. She says, "Good afternoon. Regarding the values of IH and ACS for pediatric patients, I have read on the last publication of World Society consensus that 10 mmHg is considered IH for pediatric patients. Do you believe that the new consensus will change something regarding recommendations for pediatric patients?"
Is a good point, and indeed, so in adults we have 12 and 20 millimeters of mercury, but in pediatrics we say, in fact, any pressure increase, new onset organ failure dysfunction qualifies as abdominal hypertension and compartment syndrome. So I don't think there will be much changes. Also, there is not much new literature. So I think as a whole, the previous definitions will stand. We will probably add that it's advisable not only to measure with the patient in the supine position, but also in the head of bed position. And probably we will also stress the importance of abdominal perfusion pressure, like to stress the importance of venous congestion and venous hypertension, like you could assess with VEXU score. And now we have the possibility to monitor it continuously. So I'm really excited that new data will come out on that in the future.
Thank you, sir. The next question is from Dr. Ahmed Al Masri. He says, "What about the IAP during 16-hour proning? Can we rely on it, or is there a correction for IAP in prone position?"
It's a very good point indeed, because we say that the zero should be at the level of the mid-axillary line. Of course, if you prone the patient and it's an obese patient, this could create a change for the zero reference. And by compression of the abdomen, this will increase intra-abdominal pressure. So I think it's real. So it's important, measure the pressure before, measure the pressure when the patient is supine. If you see, normally it should be 2-3 millimeters of mercury increase. If there is a more dramatic increase, I think it's, and the patient has abdominal hypertension, you should put a suspension on the symphysis and on the sternal bone so that the abdomen can really hang free and that there is not too much increase in intra-abdominal pressure when proning the patient. So yes, measure it, and sure, you can leave the patient 16 hours prone. You will see that if abdominal pressure increases a lot during proning, that you will not have a responder and you will not have an improvement in PF ratio.
Right. Thank you, sir. So if there are any more questions, please put them up. So a couple of questions from me. When does one actually think that the patient may be developing a significant IH or ACS? I mean, you have said about the need for measurement in the risk factors, but often that is not done. But generally, clinically, when should one think that the patient has developed ACS or really getting into some bad IH?
So I would suggest, because it's prevalent 25%, the incidence is up to 50% within the first week of ICU stay. My last slide showed you how it impacts everything you do: hemodynamics, kidney function, enteral nutrition, ventilator setting, and so forth. So I would say, if you have a patient in the ICU that is mechanically ventilated, not just for postoperative babysitting and quickly extubated, but a patient that is ventilated in the setting of trauma, of pancreatitis, of sepsis, of burns, that if there is deterioration of any organ function, could it be beginning of AKI? Would it be hemodynamic collapse? Then it would be wise to obtain a baseline intra-abdominal pressure measurement. So ventilated plus another organ problem suffices to start monitoring.
Right. So thank you, sir. So then moving on, let's say a patient has, developed ACS and because of some reason, and then he goes into nosocomial sepsis and, for a septic shock. And one would like to give fluids to a patient with septic shock, but fluids are bad for ACS. So what kind of a management strategy would one have here now?
Yeah, is a good point, because we need to give fluids in the early stage of sepsis. Fluids are life-saving, but fluid over-resuscitation may cause fluid accumulation and abdominal hypertension, limiting venous return, dropping cardiac output. You will give more fluids and you have a vicious cycle. So I would say that if there is an ongoing need for fluid resuscitation, then you should look for a source and you should perform proper source control. So maybe there is still some infection, the antibiotics are not good, the surgeon did not do a good job, there is an abscess, so maybe redo a CT scan and check whether source control is properly done. If that is the case, after stabilization, I think an abdominal hypertension is an issue. You should try to de-resuscitate whenever possible. And this de-resuscitation should be done if you have fluid accumulation syndrome, which is any percentage increase in fluid accumulation with organ dysfunction related to the fluid overload, and this could be an increase in extravascular lung water, but could also be evidenced by increase in intra-abdominal pressure due to bowel edema, ascites, and so forth. And then I didn't have time to discuss it. You can have the medical management algorithm. So the risk factors are fourfold and the medical management also. So you try to improve abdominal wall compliance. This you can do by sedation, by neuromuscular blockers, also by fluid removal. You can act on removing intraluminal content. So you can put a rectal probe, you can put a nasogastric probe, you can try prokinetics and so forth. Third is removing free intra-abdominal fluid. So you do an ultrasound and you check for ascites or any collections, and you can evacuate those. But the most important one is to act on capillary leak and the fluid balance. And there you could try to mobilize the excess fluids with hypertonic albumin, diuretics, and if that does not work, we start CVVH early with net ultrafiltration. So it's a medical management algorithm that you try to do in order to reduce intra-abdominal pressure, but mainly it's acting on the fluid balance.
Right, so thank you. So then another thing, pulse pressure variation and stroke volume variation is often used in the ventilated patients to assess fluid responsiveness, but these are falsely elevated in the setting of IAH. So what kind of values can we consider? Can we consider PPV at all? And what kind of values? And why are we able to understand the physiology behind the false elevations in PPV and SPV?
Yeah, it's a good point. So on average, if intra-abdominal pressure would increase from 10 to 20 millimeters of mercury, this will double the SVV PPV values because of the increase in intrathoracic pressure. So where we normally consider SVV PPV above 12% as a fluid responder, in abdominal hypertension, these thresholds will be 20-24%. So that's one. But if you have a patient with an abdominal pressure of 20 and SVV PPV is low, then it surely means that this patient is not a fluid responder. So you can turn it around. So that's one. The other thing you need to be aware is that the passive leg raise in abdominal hypertension may be false negative because the venous return from the legs cannot move to the central circulation because of the high abdominal pressure. So you can still use them, higher targets, and if they are low, they are really low.
Right, so thank you, sir. Then just a couple of more questions while we wait from the audience. So in hepatology patients, there is cirrhosis, there's massive splenomegaly, and there's massive ascites. And they obviously have some degree of intra-abdominal hypertension, and they go into hepatorenal syndrome. And do you think, sir, evacuation of fluid in these patients will help in the management of hepatorenal syndrome? Because evacuation of fluid is not there in the hepatorenal syndrome guidelines management.
Yeah, is a good point. There is few data, and that's paracentesis in combination with albumin, hypertonic albumin, sometimes terlipressin, is beneficial for solving these acute on chronic decompensations. There is not much data, but there is some studies that show in that direction indeed, that even a slight increase in intra-abdominal pressure, so a kind of acute increase of the pressure on a chronic intra-abdominal hypertension may be helpful to restore or improve kidney function in hepatorenal syndrome, because I think it's like cardiorenal syndrome. In fact, is cardio-abdominal renal syndrome. Hepatorenal syndrome is hepatoabdominal renal syndrome. So the intra-abdominal pressure is key and is mainly related to venous congestion, venous hypertension, and thereby impeding arterial influx and causing organ dysfunction.
Right. So last question, sir. So, sir, you have mentioned, and we have read this also, that you add half of the intra-abdominal pressure to your, estimated P-plat. If supposing you want a P-plat of 30, then you add half of the intra-abdominal pressure in centimeter. Is that right, sir?
Well, if the PEEP, you mean?
Yeah, no, the plateau pressure. Supposing we're targeting a plateau pressure of 30. So
Okay. If you normally target 30, but abdominal pressure is 20, then because most of the ICU patients have a baseline pressure of 10, so the delta is 10. We would say that on average you add 50% of the abdominal pressure as your target plateau pressure. But you could do it individually at the bedside. You can look at the abdominal thoracic index of transmission. If you have the simultaneous tracing of your intra-abdominal pressure and a thoracic pressure like CVP, then you can calculate it. And in some patients, it will be 50%. In others, it may be more, and in some, it may be less. So if you can individualize it, it would always be better. But as a rule of thumb, we say on average 50%.
Right, sir. So then there is I think a comment, not a question. Good afternoon, sir. As you know, there is shortage in facilities in developing countries. As an easy method to estimate the reading without new developing machine expensive query. Need to conclude the recommendation in global renal and pulmonary guidelines to become more alert to intensivist. So I think that is more of a comment than a question, sir.
Well, I think it's in the past there was this 40 manometer, which was made by Convatec or distributed by Convatec, but they stopped doing so because of regulations. So I agree that there is no real cost-effective, readily available technique. So I think it's you can design your own technique. Like I showed you, you can use the culture aspiration port, you can use a water column or a CVP column, or you can connect a pressure transducer that is already there for an A-line to limit the costs. And I agree that maybe abdominal pressure should be in guidelines on renal efficiency as well as ARDS and so forth. Yeah.
Thank you, sir. So I think this is the last question, sir. Does the pulmonary capillary wedge pressure be affected by intra-abdominal pressures?
Yeah, it's similar to the effect of abdominal pressure on CVP. Is the same for wedge pressure. So it's about 50% of transmission. But then again, you can look at it individually. So if you have a tracing of wedge, tracing of abdominal pressure, or you measure it manually with and without abdominal hypertension, and you can simulate this with, for instance, a Velcro belt or something, where you increase abdominal pressure and you look what is happening to the wedge, and then you know, but again, 50% on average.
So everybody, thanks you, sir, for a wonderful presentation. And I thank you very much for this talk, for spending your time. It was indeed an honor and pleasure to have you on our webinars. Thank you very much, sir. And for the audience, the recording will be available on our YouTube. You can review it, and you can join us again for forthcoming webinars every Sunday, 4 p.m. Indian Standard Time. Malbrain, sir, any last word from your side for all the young people?
No, thanks for giving me the opportunity to share. So please join the WSACS members portal. We will also organize some webinars, and maybe if they are interested, I think in India it's Saurabh Das and Tapas Kumar Sao. There are in Lovanish Bains. There are some colleagues there who would like to help with the India chapter of the WSACS. So everyone is welcome. Please join, and let's do some surveys and some research on these topics, as well as education and training. I apologize for the technical issues, but my computer was almost exploding.
Not at all, sir. Not at all. Thank you very much, sir. And we look forward to future meetings with WSACS, and hopefully we can carry on your good work. Thank you very much, sir.
Okay. Thank you. Bye-bye.
Bye, sir.